Good morning, everyone. Here is the article that I have to present to you guys for this week's Journal Club. This is the time course of relapse following acute treatment for anorexia nervosa by Walsh et al. This was taken from the American Journal of Psychiatry in June of this year. And I thought it was a very good article and thought there were some good talking points to go about. So I think starting off, I wanted to talk about why I decided to choose this topic. I think for some of us, this may be a review, so eating disorders continue to have the highest mortality of any mental illness. Several long-term studies have revealed that the rate's about 18%. They also have a very high lifetime risk rate. The literature shows about a rate of 4.6%, which is not inclusive of subthreshold eating disorder behavior, which the number is about up to 10% in that case. They also are disorders with a lot of somatic complications involving multiple organ systems. So just about every organ system in the body is affected by these disorders. And the more chronic and severe the eating disorder, the greater the likelihood of these serious somatic complications. There's also an increased risk of premature death. The mortality ratios, I think the risk of death is about 6.2 times higher, greater than the risk in the general population. Additionally, for females with anorexia in between 15 and 24, the mortality rate is 12 times higher than the death rate of all other causes of death. There's a lot of also psychiatric comorbidities. So there's an increased risk of premature suicide as well. About 1 in 5 deaths in anorexia is attributed to suicide. But another interesting aspect of why eating disorders is that the prevalence really affects everyone. Unfortunately, the adage or idiom that it's only a rich white girl's disease is unfortunately not true. A lot of people do consider it limited to Western culture, but there are lots of rising rates in Asia and the Middle East as well. And a lot of these disorders are generally tied to economic development, industrialization across the globe. Here is a world map of countries with reported prevalence cases of eating disorders. As you can see, the North America is pretty much covered. Canada and US have a lot, but there are lots of other places around the world that report a high prevalence. And I think I wanted to highlight quickly about where Kentucky stands when it comes to eating disorders. I think in our residency program, we have limited dedicated facilities that we can go to get exposure to eating disorders. So our exposure is a little bit limited. But I think it's important to know that rates of eating disorders in Kentucky are higher than the national average. It's estimated that about 900,000 people in Kentucky have an eating disorder. And furthermore, about 1 out of every 10 Kentucky high school students reported engaging in 3 or more disordered eating behaviors. And even more interestingly, there are lots of screening interventional protocols that take place in Kentucky schools that deal with detecting substance abuse and other mental health problems, but eating disorder behaviors are rarely assessed. So the latest update is that in 2020 there was a Senate bill, I think Bill 82, that was signed to create the Kentucky Eating Disorder Council. So there is a council of physicians that are now overseeing the development and implementation of eating disorder awareness, education and prevention programs, as well as identifying strategies for improving access to adequate diagnosis and treatment services. So that's just an update of kind of where we as Kentucky stand. And I guess the question is, why does this illness carry such a burden? the burden is incalculable emotionally, but financially, it's about $65 billion annually in the U.S. healthcare system, which is about it's about $12,000 out of pocket per person with an eating disorder. And despite a lot of the statistics, eating disorders continue to be low priority illnesses, and I think that's because there's a lot of misconceptions about their causes and consequences. And I guess this is kind of the theme of the presentation, is that I believe there's a consistent misunderstanding of eating disorders etiology, symptomatology, and treatment that really creates these limitations that further fuel misunderstanding, which further fuel this stigma, and the cycle just goes round and round, and it really inhibits any advancement to reduce this burden. But specifically, I wanted to highlight today in this paper some of the limitations that we have. What are these limitations? I think one is prevention. What early intervention strategies are we using in our practice as especially to prevent lapses into relapses? And another is detection. What strategies are we using for early detection? Right now there's no current standard for early detection. And then there's treatment. So what psychological or pharmacological interventions are we using in our clinical toolbox that are effective for patients to achieve remission and recovery? Another question is, how close are we monitoring our patients to avoid relapse? And the last question, I think, is an interesting one, and one I really wanted to highlight in this presentation. I think it's mainly interesting because of the agreed upon definitions of relapse. So going into kind of the segment of relapse, what defines remission, relapse, and recovery in this illness? The definitions for all of these vary very considerably in the literature, which is really problematic for treatment. How long do we continue assessing patients who are in remission? At what point do they relapse? When do they reach recovery? And if we develop definitions and standards for these stages, this will better help clinicians understanding and potentially reduce that stigma that we saw. It further helps us understand the stages, like I said, of this illness. So going into the paper in this kind of background piece, they too argue that there's longstanding interest into how best to define illness in anorexia. It really guides clinical management and research, and it's really important to define remission and recovery. So in the background, they highlight a landmark paper that was written in 1991 by Dr. Frank that highlights the consensus definitions in terms and major depressive disorder, like remission, recovery, relapse, and recurrence. They found considerable inconsistencies across and even within research reports, and concluded that research on depression would be best served by creating greater consistency in these definitions. So they basically proposed this conceptual scheme for these terms and criteria for each term. They also proposed that the stages be based on illness severity and illness duration. For example, remission would be classified as a relatively brief period during which the individual is asymptomatic. And further in the stages, they also highlighted a point of rarity, so a period where very few patients experience a return of the syndrome. This would be useful to plot, especially among individuals who are in remission, as this inflection point at which the risk of symptom return would be diminished. They said that this, they argued that this could be determined by empirical methods. As I said before, they wanted to find this inflection point at which the risk of symptom return clearly diminished. So only 2 other studies have tried to identify the rate of relapse over time in anorexia. Neither of them was able to identify this kind of inflection point suggested. These studies were done in 2002 and 2020. So this study that I'm highlighting examines data from a previously published study regarding relapse in anorexia to determine whether that point of rarity could be identified. So this could suggest a criteria for duration of remission after which the individual could basically be considered recovered. And it would just be helpful to judge the need for an intensity of ongoing treatment, and also to determine the length of intensive treatment for the patient. So the methods used in this paper, the data was derived from a 2-site study examining the effect of fluoxetine compared with placebo in preventing relapse among 93 weight-restored women with anorexia. This was done in 2001. To be eligible for this study, you needed to successfully complete a weight restoration treatment in an inpatient or day hospital program. Day hospital program, another name is the partial hospitalization program. And upon completion, their BMI needed to reach at least 19. For context, normal BMI is classified by the CDC as 18.5 to 24.9. And the literature suggests that the average BMI of weight restored patients after completing acute treatment was around 19.2 to 22. So just to give you context. The patients in that study were randomly assigned fluoxetine or placebo. So the rationale for using fluoxetine was that in a previous study by that group, they saw that there were modest improvements in eating behavior, mood, and obsessional symptoms with the administration of fluoxetine. And so they were curious if it could help prevent relapse after weight restoration in individuals with anorexia. This dose was then raised to 60 milligrams for about 1 week, over 1 week, excuse me. The rationale for this was that many patients with anorexia have comorbid depression and obsessive compulsive disorder, and that dose would be helpful for both of those diagnoses. And throughout the study, the psychiatrist could raise fluoxetine to 80 milligrams daily if the patient was seen to be deteriorating. The procedures in the original study, the subject or patients received cognitive behavioral therapy after discharge from that acute inpatient stay for about 1 year. They initially received it twice weekly for the first month, once weekly for months 2 through 11, and then once every other week at month 12. Patients were weighed at each visit, and patients were asked about whether they engaged in binge eating or purging at the visit. Since all patients that had entered the study, their BMI, since their BMI was greater than 18.5, they were considered to be in remission at the time of study entry. So in the original study, the primary aim was to determine whether fluoxetine extended time to relapse compared with placebo. The primary outcome was time to relapse, and this was examined by survival analysis. And so in the original study, 40 of the 93 patients completed the study, and those were considered not to have relapsed. The key question was how many of the other 53 patients had relapsed. So it leads the question in the study as to what is relapse. So In the original study, 20 patients met criteria for severe deterioration and were withdrawn from the study and referred to a higher level of care. Those criteria were the following. Their BMI fell to or below 16.5 for 2 consecutive weeks, or they had severe medical complications arise, or the participant was judged to be at an imminent risk of suicide, or the participant developed another severe psychiatric disorder requiring treatment. In addition to that, 6 patients were withdrawn by the investigators because of non-adherence or side effects they experienced along the way. In the present study, it was anticipated that a substantial number of patients would withdraw from treatment during this 52-week study. So to assess this, they developed 3 sets of criteria to assess whether any of them had relapsed. In the first analysis of these withdrawn patients, they said, okay, all patients who failed to complete the study are classified as relapse. So this, they use this as an analysis to remove any investigator judgment or potential for bias. If it was suspected they were on fluoxetine or placebo. And this primary analysis was also identical to the original study for this original study's criteria for relapse. So by this criterion, all 53 patients who failed to complete the study were classified as relapse. So the second set of criteria that they came up with was that only patients who were with severe deterioration were considered to have relapsed. So the data from other patients who withdrew for reasons other than severe deterioration, that data was censored. This analysis, like a primary, that was created and designed to minimize bias. So by this criterion, only 20 patients were to have relapsed in the original study. And then the third analysis that they created was a clinical assessment of the patient's condition at the time that they dropped out. So before breaking the blind regarding assignment to fluoxetine or placebo, the investigators classified non-completers as having relapsed on the following criteria. If they had a BMI less than 17.5, if they were binge eating and or purging 2 or more times per week for the full weeks prior to dropping out, if they exhibited depressive or anxiety symptoms sufficient to interfere with functioning, in other words, something like serious suicidal ideation. And by this criteria, 44 patients were classified as having relapsed. So in other words, 24 out of the 33 patients who dropped out or were withdrawn for reasons other than severe deterioration were clinically judged to have relapsed. So using each of these methods to classify non-completers, the survival analysis showed that there showed no indication that fluoxetine extended the time to relapse compared with placebo. The purpose of the present study was to describe the time course of relapse following entry into the study. And in the present study, they decided to use that tertiary analysis, that third set of criteria to classify relapse. And it was deemed superior because it captured the patient's clinical state at the time they dropped out. They also did an additional supplement to this article where they used the primary analysis for relapse to describe the time course, but they did not feel that, assuming the other 33 were, they just didn't feel that that was a clinically sound assumption. they just thought that such an analysis would be descriptions of the time to severe deterioration and not the time to relapse as clinically judged. And then for the analysis, for each day, the risk of relapse following 60 and 90 days was calculated on a Kaplan-Meier estimator. And to describe the time trend, they fitted a parametric function to approximate the Kaplan-Meier estimator using the following equation. This is used to fit survival outcomes to accommodate basically nonlinear hazard functions. So moving on to the results of the study. So they saw that the mean age of participants was about 23 years old. The mean BMI was about 20. And the mean duration of illness was about 4.5 years. This is the first graph that was seeing the probability of relapse in the next 60 days. As you can see, the probability of relapse within the next 60 days at day 0 was about 6.6%, and that maximum risk of relapse was on day 66, and that's when the probability was about 19%, 19.3%. Moving on to the next 90 days, as you can see, that at day 0, the probability of relapse within the next 90 days was about 17%. And the maximum risk of relapse was on day 54, when the probability was about 26.8%. This is the supplemental article that I had mentioned earlier that they did. Again, they felt like using this criteria for relapse was just not clinically sound, but they did fit the Kaplan-Meier estimator and made those calculations here that are very similar to what we saw in the tertiary analysis. So kind of reviewing those results, as we saw in those figures, the risk of relapse rose immediately after entry into the study and reached a peak after about 60 days and then gradually declined. There was no indication of an inflection point at which the risk of relapse fell after the initial peak. And as I said before, the figures S1 and S2, those supplemental figures from the analysis, they showed similar results to using the clinical criteria for relapse. So in reviewing the results, in looking at the peak relapse rates, when looking at the two criteria for relapse judged clinically versus all withdrawal is classified as relapse, the peak risks did not differ significantly. When it came to the site, New York versus Toronto, the peak risk of relapse at the New York site was significantly greater than that at the Toronto site. When it came to the subtype of eating disorders, binge eating versus binge eating, purging versus restricting, the peak risk of relapse for the binge eating and purging subtype was significantly greater than that for the restricting subtype. And then looking at the days of peak relapse between all of those comparisons I just mentioned, when it came to judge the two analyses of relapse, the days of peak relapse when relapse was judged clinically was about 66 days. versus the primary analysis of relapse, which was about 53 days. And then when it came to the site, New York versus Toronto, the days of peak relapse were about 57 days versus 110 days seen in Toronto. And then when it came to the subtype of eating disorder, the days of peak relapse were about 57 days in the binge eating and purging type versus 110 days in the restricting subtype. And the comparisons of relapse rates over the next 90 days, they yielded similar results. So moving on to the discussion piece. So some of the strengths of the article, one is that it's a prospective controlled trial, and prospective studies usually have fewer potential sources of bias and confounding than retrospective studies. Patients entered the study at similar normal BMIs, and criteria for relapse were based on clinical assessment, as opposed to the other analyses. Limitations in the study, there were quite a few. One was that the analysis was largely based on body weight. It suggested that a full range of physical, behavioral, and psychological measures be used to assess remission and recovery. All patients had been weight restored with a highly structural, behaviorally oriented intensive treatment. So, what about other patients treated in other settings and to other degrees of weight restoration? That was a question. So patients were also all women, and patients were followed no more than 12 months. As we saw earlier, that the mean duration of illness was about 4.5 years for our participants. And this study was initiated over 20 years ago. And it might be argued that CBT is an outdated psychological treatment for anorexia, but no superior treatment methods have since been identified. So in the discussion, just to kind of review, there was a transient increase in the risk of relapse in the 2 months following discharge. So despite frequent use of CBT, it's likely that the substantial decrease in support and monitoring behavior contributed to that transient increase. There was further analysis and work done on the data that suggested that there was a critical element, that the critical element really increasing relapse risk was a reduction in caloric intake from the amount consumed in the last weeks of acute treatment. Patients who returned to their pre-treatment patterns and food intake were at high risk for rapid relapse. And after those first 2 months, the risk of relapse fell steadily over the course of the study. So the longer the patient went without relapsing, the lower the risk of subsequent relapse. So these results don't necessarily follow the model suggested by Dr. Frank, in which this inflection point in the change in risk over time can be identified. So in the present study, when we compare the peak relapse rates for both the sites and the eating disorder subtypes, the peak relapse rates were lower at the Toronto site and for the restricting subtype. Peak relapse rates, when all dropouts were considered relapse versus the clinical judgment of relapse, those did not differ significantly. Comparisons of the time courses of relapse of different groups of patients using parameters that were derived by the model should be interpreted with caution, the paper highlights. So the statistical model yielded a specific day which the relapse rate had been greatest. And it was seen that with examination of the curve that the rate of relapse actually gradually rose and fell rather than reaching a sharp peak. More importantly, the study was to describe the time course of the conditional risk of relapse, not to really compare the effect of side or disorder subtype on the time to relapse. So few studies have attempted to really develop a definition of recovery on the analysis of the course of patients. Comparisons are difficult because of methodology. The couple studies I did mention, one used follow-up data from a 2.5 year study that they concluded that the duration is not a strong predictor of stability of the stages of full remission and recovery. The other analyzed data from about 246 women and over about and were followed for about 9.5 years. They found that among patients after symptom remission had occurred, there was a gradual decrease in the risk of symptom return over time, but they were also, like I said, unable to identify this inflection point when the risk of relapse changed dramatically. And so neither of these studies, nor the present analysis, was able to identify empirically a duration of symptom remission that supported a declaration of recovery. Rather, it basically said that the longer the duration of remission, the lower the relapse, lower the risk of relapse. Review the studies of the time course of major depression of that landmark paper, there was another paper that similarly found evidence for a specific duration of remission after which a patient could be declared recovered. It further articulated that the risk of relapse gradually diminishes as the duration of remission lengthens. Again, like I've said before, the analysis highlights that patients with anorexia are at a huge increase of risk of relapse in the first months following discharge from acute treatment that results in full weight restoration. So this suggests a need for a step-down care focusing on maintaining caloric intake and whether it be through partial hospitalization program, day program, frequent follow-ups, or relapse prevention focused treatment. The time course is described here is seen similar in like high risk of suicide in the first weeks following discharge from hospitalization for other psychiatric disorders. And this just underscores the risk of symptom recurrence following discharge from intensive care. It just, again, like I said, it just provides a clinical rationale for conceptualizing that first post-discharge month as a distinct phase of recovery and treatment, especially in the context of pervasive gaps in treatment for these disorders. In summary, after approximately 2 months, the risk of relapse in anorexia progressively decreases over time. Although it may be useful for administrative or research-oriented reasons to declare that patients with anorexia have recovered, it should be realized that this is really chosen arbitrarily. And there's no specific length of time that's suggested by empirical evidence. So what does this study say about clinicians and eating disorders? Well, the literature's understanding of anorexia continues to be poor from kind of what I'm gathering. We don't really know what kind of illness this is. Is this relapsing and remitting? Is this recurrent? Is this episodic? We just can't come to an agreement on their stages and a description of the time course. And we also aren't in agreement of the standard definitions of relapse, recovery, or remission. And also, clinicians are not well equipped from a pharmaceutical standpoint. And by that, I mean that there currently is no FDA-approved drug that exists to treat anorexia. And I also think from a psychotherapy standpoint, targeting anorexia is limited in the research. It's it's scary that 20 years ago this was done and using CBT, and there's been no superior method developed in the treatment for this disorder. So how does this information apply to my practice? I guess I kind of phrased it as to 3 different categories. One is to the student, so to medical students and students in general, when they're seeing eating disorders are very complex psychiatric illnesses that not only require a thorough psychiatric history, but also a thorough medical history. As I kind of highlighted in the beginning, that this is a disorder of many somatic complications that could arise and a high mortality rate. And you should really practice when you're doing histories on patients of asking the right questions and being thorough with the information you gather. To the resident, I think one important note that I gathered was that patients' body weights should not be the only measure for relapse or remission in your clinic. I think that's a really important point. I think we discussed that, the psychological, behavioral, and physical and psychological behavioral part of the recovery for patients with anorexia. But it should also be noted that psychological and behavioral recovery cannot occur without nutrition. So just re-emphasizing that for patients that are acutely ill, proper nutrition is truly the gold standard of therapy in these patients. To the attending that is following patients with eating disorders in their clinic. So one piece, stepping down from an inpatient hospitalization to weekly psychotherapy and weight checks can really be a slippery slope. As I said, like a fully integrated step-down model would really be needed to, and you need to incorporate several levels of care as they exit that inpatient setting. So the ideal scenario would be for patients to undergo inpatient renourishment, this residential treatment program, a day program, intensive outpatient treatment, and then outpatient treatment. And I know that it's our resources are lacking, and so I think there have been novel additions to help accommodate some of those gaps. And I think some of those include home-based care, virtual care, and other digital adjuncts that could possibly augment the traditional levels of care that are needed and really reduce the chances that a patient needs to escalate to a higher level of care just after returning home. And I guess that leads me to my next point that appropriately paced step care is rarely achievable in the US. And patients and families really scramble to find appropriate step-down options, and they often crisscross institutions and even states to access services, leading to a lot of gaps and no continuity of care. You know, an example would be someone who goes to inpatient treatment in Oregon, then to residential across the country in Pennsylvania, and then back to their home in the South for outpatient treatment. And that just is a mix and match of evidence-based and idiosyncratic care, and that really does a kind of a disservice to the carers who may be differentially involved across sites. Also, it's just very costly for patients and adds to that burden of the broken system. You know, going along the lines of the applying to the practice, you know, that just ever, you know, means you should be vigilant as really an attending resident or student to make sure that your lapses don't turn into relapses. And in that sense, that I hope that, like, you know, with time and with further application of and understanding of these definitions, we can really reduce this burden and reduce it by creating more opportunities for treatment for eating disorders, and by this gain understanding of how they work and what they are and where they come from, and hopefully develop you know, acceptance for their treatment. So that is all I have. Any questions, comments?
Don't forget to check the Q&A down below then there.
Oh, excuse me. Excuse me.
You might want to read the question aloud.
Oh, excuse me. I'm sorry. You're right. Thank you. Nick highlights in the Q&A that in the paper, one of the limitations mentioned was that the data collection occurred 20 years ago. Authors felt like this wasn't a significant limitation as the treatment for anorexia hasn't markedly changed. Do you feel like there have not been any improvements in treatment protocol that would change the results if the studies were to be repeated present day? To answer that question, I do think that from a psychotherapeutic standpoint, since I believe kind of that limitation was really highlighting the use of CBT, and if that was outdated, I do think there's a lot more evidence towards dialectical behavioral therapy, and I think up and coming acceptance and commitment therapy has a place for treatment in anorexia, and so I feel if that was incorporated into the treatment protocol, I think there may have been some minor improvements, and I would be curious to see the results if that were to be replicated with those different psychotherapeutic techniques. As far as dronabinol being used as a pharmacological treatment option for anorexia, I do not know the current status of if it's currently being studied as an option for anorexia. Typically, you know, my understanding is that appetite stimulants are really are not the primary primary means of treatment for these disorders, and but I still think there are a lot of questions to be asked about dronabinol, and I think when it comes to the different subtypes of eating disorders, I think dronabinol could maybe have more efficacy in something like an avoidant restrictive food intake disorder. So someone who specifically, you know, has a desire to eat and wants to overcome the anxiety surrounding his or her somatic complaints. I think that could have a use, but as far as it's being studied, I'm actually not sure myself. Other questions?
Hi, Davis. Hey, this is Dr. Huang. Can you
Hey,
hear me?
Dr. Wong. Yeah, I can hear
Yeah.
you.
So yeah, I recently I have some dealing with acquaintance. Their children have eating disorder, and so I think I understand it's very hard to treat.
Mhm.
And so I think you're talking about acute and subacute relapse. Like in addiction literature, they talk about before patient go into full remission, and then it takes 10 to 15 tries.
Mhm.
So they go through treatment and stuff, So if you look at the long-term relapse risks for people with eating disorder, how many, round of treatment do they need before they finally, you say, fully recover?
Mhm. And that's a really good question that I think a lot of people have. And I think if you were to answer that, you would be a very wealthy person, and really reduce a lot of burden on on this disorder. I think the recent data that I read shows that, up to 50% of patients will relapse after their first cycle of treatment. And there's just a lot of factors that play into patients who go back into treatment, and partly is there is this economic burden, and there's just a huge psychosocial component to this disorder. So there are a lot of questions as to how long, how many tries does it take through treatment.
Mhm.
And I think that's the goal, is to reduce reduce this revolving door cycle that we see in these patients that really adds to this burden.
Yeah, another thing I want to mention is like, sort of like I talked to, Dr. Carl from, child inpatient service. Actually, these days, most children with eating disorder are treated on medical floor because they have bradycardia, electrolytes disturbance, hypothyroidism. So, and then the insurance company only pay for medical treatment for eating disorder on inpatient service. And then, so once those things are addressed, and then they were shipped to like a residential treatment center for a while. And then supposedly they were required to eat up to 4,000 calories a day.
Mhm.
And then if you don't eat that amount, they'll tube feed you, that kind of thing.
Mhm.
And then they come home, and then quickly they just go back to old habits, relapse. And
Mhm.
then, so as far as I understand, the relapse rate is really high. It's
Mhm.
very,
Very high.
and
Very.
then, yeah, another thing is like somehow it's treated as a medical problem.
Mhm.
Insurance company only wanted to pay for medical treatment part of the problem rather than psychiatric, treatment.
Mhm. Mhm. And that's a huge barrier for a lot of patients today, is qualifying for insurance coverage. And I mean that's everybody, I think, who has an eating disorder right now. So I completely agree. And it's such a hard thing to come from such an environment. I think when I mentioned the post discharge, that first month is especially hard for these patients who are essentially very much doing nothing from an energy expenditure standpoint, and come home to a very busy world, especially in Western culture, and have this have to keep up with lots of keep up with their diet and keep up with their caloric intake. And so it's a slippery slope, basically, is what I'm saying, when you come out of that acute inpatient treatment, being acutely ill.
And then supposedly Facebook and Instagram doesn't help either.
No, it does not. It does not. That's a huge barrier to treatment, is social media.
All right, thank you.
Thank you, Dr. Wong. Any other questions or thoughts?
All right, if there are no further questions, I think we can end the program, and this will be posted later if anyone wants to review it or send it out to those who are unable to attend. Thank you.